this week on the BackTable podcast.
Once we did get our equipment, though, we were able to show a statistically significant reduction in pain in those who experienced VR compared to those who received no intervention. They also actually had a decrease in their heart rate during it, which is a commonly looked at metric as sort of a biofeedback piece for any sort of relaxation intervention. So, it's nice to see, the secondary outcomes sort of line up as well.
Hello, everyone, and welcome to the BackTable OBGYN podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on BackTable.com. Welcome to the BackTable OBGYN podcast. This is Mark Hoffman, and I am excited to bring two good friends onto the show, one of whom is a little more familiar to our audience, one of our co-hosts, Tony Shanks, who is a maternal fetal medicine doctor at the University of Indiana, who's vice chair of education there, as well as fellowship director for their MFM fellowship. How's it going, Tony?
It's going well. Thanks for having me.
Yeah, we're excited. And we have a very special guest to both of us, a mutual friend and someone who we just love spending time with, Dr. Melissa Wong, who is an assistant professor of OBGYN at Cedars-Sinai out in California. She has a dual appointment in the Division of Informatics and also works with the NIH Office of Research on Women's Health. Melissa, Dr. Wong, I would say, but I've known you forever, so is it okay if I call you Melissa?
Melissa's fine, absolutely.
Okay, I would be sad if I had to call you Dr. Wong just because I've known you forever, but welcome to the show.
Thank you. It's really great to be here.
So tell us how you got into virtual reality in labor, and so that's what we're going to talk about today, and just virtual reality and its role in obstetrics and gynecology and in medicine in general. But you've written about this, you've published about this. Talk to us about how you got to where you are, both in your professional career, but also in your research interests.
Yeah, absolutely. So I would say the path was honestly kind of serendipitous in many ways. I came out of OBGYN residency and was a generalist for a few years. And so really was sort of in the thick of it, delivering patients at whatever time their baby felt convenient to be born. And so saw a lot of patients who really came in having ideas regarding their own pain management. And so really sort of saw that firsthand in that way. And then concurrently, I started a maternal fetal medicine for high-risk pregnancy fellowship, and concurrently also did a master's in health delivery science. And the focus of that master's is really on digital health systems, and cost effectiveness and healthcare value and epidemiology, sort of all of the things that we're trying to figure out how to do broadly better. And it was a wonderful experience. It got me into some of the research that I do now, which is on artificial intelligence. And one of the projects that I did during it as well was this one on virtual reality for laboring patients. And it was really in the context there where other Cedars-Sinai just has a really robust virtual reality, or I should say now what they're calling sort of mixed extended reality, run by Brennan Spiegel and his group. And they were looking, early on for potential use cases. And it's really sort of hard to find an area of the hospital where pain is manifest more regularly and steadily than labor and delivery. And so it was really that sort of prompting of them saying, we have this thing, it was just very much in sort of the nascent days of any sort of trials around virtual reality, period, in its use as a therapeutic. And, do you all want to try it in labor and delivery? And we said, yes, but like many things in labor and delivery, we want to actually see that it works before we actually start recommending it to patients.
So were you like pinching yourself while you were wearing the device? Like how did you see that it worked before you tried it on patients? What was that?
Oh, I should say, no, I would want to see that it worked before we just made it available, from the menu of stuff that people will actually bring to labor and delivery. So I think that there are variable things that actually do and don't work. And we just wanted to make sure that if we were going to recommend this to patients, that it actually was clinically meaningful as well.
So they were coming to you saying, we want to do this just as a clinical service to our patients without really any
with nothing
data.
With nothing, yeah.
Well, it's fascinating. I'm excited to hear more about all this. To the audience, to listeners, Melissa was a resident when I was a resident at the University of Chicago, so we've known each other for a very long time. And it was always like, oh, she's going to be big. I mean, she's going to be huge someday. Everyone just you work with her and you're like, I'm the worst compared to her. I mean, it was just such a joy to work with you. Honestly, it was like whatever team you were on was just better because you were there. So I think working with you and just being around you is such a joy. And then we all got to be APCO Scholars classmates and meet Tony, which the three of us together could be trouble at times. Small cars and big buffets. But anyway, I just think the world of you, and I'm excited that you're here today. So Tony, why don't you help us understand this?
Let me jump in here because this is kind of a fascinating topic, and I want to lead the audience through the process because I was actually there at the conference that you presented, and I could get the sense from the audience that were just kind of in awe of your command of the room and just the presentation. So before we get to the actual data that you presented, I'm curious because it's so novel, using things like VR headsets to decrease pain. What was it like dealing with the IRB?
Dealing with, the IRB actually wasn't bad. There seems to be this little space when something is FDA, oh goodness, there's a word for it, but fine with it, but also low expectations of it. And that's sort of where these ended up falling at the time. And also because, again, sort of benefiting from it already happening in other inpatient settings. So they were walking around and, putting it on the heads of patients with sickle cell disease or with inflammatory bowel disease. And it was just sort of, when were you going to catch them when they were in pain and whatnot? So we were able to really leapfrog over a lot of the sort of mental hurdles probably for the IRB and the wording hurdles and be able to deploy relatively easily.
So can you briefly summarize the findings from that study that you presented at the Society for Maternal Fetal Medicine?
Yeah, absolutely. So it was still to date the largest and longest randomized control trial of virtual reality in laboring patients. We basically recruited patients who were in their first pregnancy because we wanted it to drag out and had pain scores of between 4 and 7. So we wanted them to have some degree of pain, but not be too far gone. We also required that they hadn't had any sort of pain medication. So even if they had, fentanyl hours and hours before, they were still not able to use it. It was only those who, of course, didn't have any sort of an epidural, but also hadn't received any version of pain medication. And they got randomized to either up to 30 minutes of virtual reality or 30 minutes of no intervention. And we looked at basically what their pain score did from before to after the intervention. We also actually got other interesting data around sort of self-perceived anxiety, self-efficacy, as well as actually tracking maternal vitals and the fetal heart rate during as well and sort of documenting on that. So we were just sort of, how it is, just getting everything that we could to see where it might have effect. And we were able to recruit over the course of just over a year. Had I been recruiting dads, it would have been far more successful because they were always volunteering, but shockingly had little to do with pain management for a person's labor. Once we did get our recruitment, though, we were able to show a statistically significant reduction in pain in those who experienced VR compared to those who received no intervention. They also actually had a decrease in their heart rate during it, which is a commonly, looked at metric as sort of a biofeedback piece for any sort of relaxation intervention. So, it's nice to see, the secondary outcomes sort of line up as well.
Yeah. When we think about toys and devices, people tend to be satisfied when using something novel. So to get that next level of impact and using this heart rate is just an ingenious way to do it. Can you describe the VR headset that you used and what they were watching?
Yeah, absolutely. So the headset was actually pretty old school. It was like the original Samsung headsets that had to have the phone actually attached to the carrying headset itself. But what they were watching was essentially 3 different nature scenes. The first one was this tree sort of swelling and then relaxing that people flatteringly thought was on purpose, but it actually just was an incidentally pleasant nature scene. There was also a campfire, and then the third part was sort of these waves crashing on the scene. What was probably, quite frankly, more relevant than what they were seeing was actually what they were hearing. So the company with whom I have zero affiliation, but they actually had enlisted a doula to create their narrative guidance for the virtual reality. So while pretty much every study I've otherwise seen oftentimes uses just a generic scene, what I thought was really incredible about this intervention, and probably what got me interested in it, was their willingness to create actually guided content that was relevant to a laboring person. So they would actually hear, think of the waves as, bringing your baby closer to you, your something, goodness, it's funny. I have the hardest time saying this because I'm like the least crunchy person. Something like contractions are also like waves of energy and other very helpful things when one is in labor. So they were actually like focused on the actual task, which in our follow-up study, sort of looking at the qualitative piece in the interviews that we conducted afterwards, turned out to actually be really important.
Remind me, where did you present this? Like what city were we in for SMFM?
We were in glorious Dallas. I think we were in Grapevine.
That's right. What year was that?
It was the last SMFM before COVID.
Okay.
So it was, was it 19, right? No, 20. Right, because SMFM's in January. So yeah, 2020.
Okay, so I remember when you were on the stage, I was like, oh, I know that person. This is such a cool project. And I remember just like everyone was just like watching you because it was not just a cool project, but like you were funny. You injected humor into it. And I am certain that you got a lot of great feedback immediately afterwards. Can you tell us like what people came up to you and said after that presentation?
Mostly that they were pleasantly surprised by sort of, I guess, compared to what they thought going into it. It's anything, right, that's sort of out of our standard wheelhouse, and especially at SMFM, anything that's not, finding the next cure for preeclampsia. It's a little bit of a harder sell. And so I think a lot of people were like, yeah, I thought it was going to be kind of BS, but it was really interesting. And yes, I definitely make sure, actually from our medical education learning, to literally like timed script in actual like moments of levity or something to sort of break up the glory of presenting 5 slides of a methods section.
Well, it was a master class on a presentation. It was great. I'm curious, with the age range of the patients in your study, I think a lot of them are going to fall under what we call digital natives. They're used to technology and using that. Maybe going beyond the study population that you looked at, do you think other people that may not be as in tune with virtual reality would have gained the same benefit? Do you think there are barriers?
Yeah. I think that, our general like sort of laboring patients are all in very much digital natives. I would say though that like if we look to the other studies where it's been used, there actually is not as much of like an age drop off in any sort of a way. In like any intervention, there's going to be, sort of a peak in the middle. But really, whenever you look at sort of predictors of benefit, some of the coolest stuff that's happening, quite frankly, outside of OB, to me, is some of what they're doing in neuro rehab. And so these post-stroke patients, of course, span all age ranges. They're able to iteratively actually improve their neuro rehab by doing it in the context of virtual reality. Something about it just kind of makes them willing to stretch that extra little bit or, just do that little bit more to beat the game to sort of get them rehabbing that much more efficiently.
Yeah, I think that's a nice segue to things I wanted to ask you, especially in light of what you're doing now. When I was doing a PubMed search, looking at your study with virtual reality and obstetrics, there's not that much. And it's only been in the recent years. When you start to expand that to other specialties, you see like orthopedics and neurosurgery. Where do you think virtual reality is going? And let's start with OBGYN before we go on to other specialties. Where do you think VR specifically is headed?
Yeah. So VR in OBGYN, and I say this at every presentation that I give, especially to trainees, is wide open. Like it is just, I mean, you can sort of look in any aspect of it, whether it's the therapeutic piece like we did in our study, whether it's education, whether it's the patient experience components. I mean, and tragically, like as is the case in many OBGYN topics, is sort of just this like stepchild, despite it representing such a massive component of our healthcare and our national healthcare. So it really is entirely untapped. So they're, outside of OBGYN using it actively for therapy, especially whenever you look at things like mood and anxiety disorders, whatever you look at, any uses of cognitive behavioral therapy, they've translated that into headsets as well. And there just hasn't been the same push, and for absolutely no reason, especially given that, again, intrinsically our patient population is really that prime age for it. So I just encourage any coming after me to start doing it, because whether it's, little procedures, whether it's short interventions like what we did in labor and delivery, or if you want to actually create something.
Well, that's what I was thinking of when you brought this up. Was we always think about putting someone through a procedure in the office. As you know, I do gynecology only, putting in IUDs, colposcopies, endometrial biopsies that, having never had one, I can't speak to my personal experience, but they look like they're no fun. And I had a patient the other day, looking at the ceiling, asking, next time you ought to hang a Where's Waldo, just so I can be distracted. But I mean, that's a perfect example of a way to keep a patient in another place, because I think most people who come to the gynecologist would rather be any other place than where they are, especially on a beach or something like that. Have you heard of anything being done in that way in gynecology for those types of things?
Yeah. So one study I know of that actually was performed just down the street at UCLA, they had used it in first trimester DNCs. And it was a smaller study, but I can't recall, honestly, if it was done as a trial or if it was done as just sort of an observational study, but they definitely had positive results from it. And I think that, and we actually are sort of making our only second avenue into virtual reality and working with a resident of mine who I guess heard me. So he sort of keeps saying, like, somebody should be doing more of this. And we're going to be using it for in-office procedures for gyn-oncology patients, just because that's sort of, her overall interest.
To use as a pain,
Yeah.
like a distractor to decrease pain?
Yeah, a pain, yeah. So it's sort of a combination of things. It's sort of a distraction. It's decreasing of interval time is sort of the second mechanism. And then the third is actually that there are changes in kind of the actual gate control of pain signals. And they've shown that the nice thing is whenever you jump into sort of the pain sphere, there's been so much work done on this, not in OB, but where you have like actual evidence to go off of. So some of the earliest uses were in pediatric burn patients where, they have to get these dressing changes so frequently. And they would actually put them in a headset in an icy environment, and it would make it all a little bit more tenable compared to not having it on.
And also as an intervention, like the risks are low, right? I mean, when you're like back to Tony's point about getting IRB approval, like
the risks are extremely low. Yeah.
It's, if we have the TV on during this procedure, right? The impact, I would imagine the negatives wouldn't necessarily be as high, but maybe Tony has some other.
Well, I told this person I would not implicate them. I did mention the topic, and we were talking about using VR headsets and just how immersive it can be. And this person was completely disoriented and kind of fell and hit their heads. But it speaks more to like how completely into the virtual reality they were.
Oh, right. I've seen those videos of the people playing their video games and like running into walls and things.
Yeah.
I guess it is not totally risk-free.
Not entirely. No, it was mandated that they stayed in the bed actually. So there were patients who actually, they were just so uncomfortable they couldn't sit in the bed at that point. And they were actively excluded because nobody wanted to fill out that adverse event form. It is insane how sort of immersive it can get. I think that, if you guys have seen the videos of folks who have phobias and are actually getting their cognitive behavioral therapy for the phobia via VR, like especially sort of the heights, the fear of heights, folks. You'll just see people like wearing a headset. Clearly they just put it on themselves. They know exactly where they are and they are just sobbing from fear because they're being made to, quote unquote, walk across a plank, in their headset, or they're having something, they're on the scaffolding and everything drops in front of them. So they don't have the protective barrier between them and the floor that they're standing on. And yet
we have a set, and my teenage son, I remember him taking the headset off because Darth Vader was just around the corner. So they really do make you feel like you're in there. I'm curious, Melissa, outside of studies, are you using virtual reality for education for residents or medical students where you're at?
So we have not employed it, but there's definitely a lot of work done in this space. Again, unfortunately, outside of OBGYN. There's one company I saw who is out of the UK who created a lot of emergency department sort of focused content. And one of them was sort of incidentally OBGYN, but that is as close as I've ever seen. So I think that in medical education, there is so much potential. I mean, whether it is in creating, actual scenarios sort of akin to sim, whether it's actually, where everybody sort of wants to get to is, it actually being used as an operative simulator. I'm less impressed by that in all fairness. I mean, there's just only so much they can do for now. I think that that's changing.
The area where I've seen that change, and, sim is not immersive in the same way, not always immersive in the same way that VR is. The robot is different because you don't have haptic feedback in real robotic cases. So the simulation cases are much more realistic. I never enjoyed the sim with straight stick laparoscopy. It didn't feel real. It didn't feel like I was learning a whole lot, it just seemed like a lot for not much ROI. But the robot felt very different because your head is in the booth.
Yeah.
And it is pretty immersive. And I think the closest that I can sort of think of what's being done now is just with the robot systems, but that's also very limited. It's not total virtual reality in the same way.
Yeah, I think that I think the robot does a phenomenal job, actually. Because you're literally on the console that you would be using, in the actual surgery, there's really no translation there. Really, you're just doing it from what you'd be doing. You might be sitting in a slightly different back chair, but that's about it. Whereas, translating from I'm wearing a headset and I'm performing a laparoscopy with joysticks, it's a little bit heavier of a lift to me. And also there is a complete, sort of today, at least, a lack of real instruments that simulate that, let alone sort of thinking about what happens, in an actual open type case to simulate something like that. So I don't think that we're there yet. I think others are getting closer. There was actually probably one of the most compelling examples was one designed by for orthopedic surgery residents, right? So they use a lot of things that actually do kind of work, like joysticks and bang around and everything. And so their simulation was actually really compelling. I think it's called OSSO VR. But as far as what I've seen for OB, the surgical piece of it, I think, still is going to take some time. But I think that maybe the sort of less sexy version, but at the same time, probably more compelling version for its use in medical education is actually to replace some degree of in-person sim. If you think, for any of us who had to put on an in-person sim, what that takes in terms of getting 20 staff there from all different disciplines, we can maybe get it scheduled, with a really active program 4 times a year to really do this. And how many residents do you actually impact? So I think that the ability to create that in virtual reality would actually be really incredible. You could simulate a maternal cardiac arrest, or simulate whichever you choose, sort of, a shoulder.
And that's where I feel like VR would actually be a benefit because, like you said, sims are, and having done a few, they're much more, I think, prevalent in obstetrics compared to gynecology, but it takes a ton of resources. The space and the people and just getting an ICU or an OR that's even simulated. It's a massive, massive, massive lift. Once you've built the system, the machine, the environment, you would think it would actually probably be more efficient than a sim. And that's interesting. Yeah, I agree with you. I think sims can be helpful, but they take a lot of people, a lot of time, a lot of space.
As well as consistent. And also, I mean, the nature of, right, like getting to, do this in a room by yourself with a headset on, there's a lot more psychological safety there than even in a sim. You still these are the people who you're going to work with tomorrow. And if you don't feel comfortable, or if it's easier to sort of joke it off rather than, show that you're not aware of how to do something, then I think it becomes more beneficial potentially to, be doing it in a headset.
Yeah, I think in applying it to like medical education, it's an easy step to think about like our first couple years of medical school before Zoom, when we were actually in classrooms and hearing a lecture. And then, moving to Zoom gave the benefit of like, we didn't have to be in, the same place, but you lose that presence, that connection with people, and, putting on a virtual headset so that way we could virtually be in the same room. You can leverage the expertise from people all across the country. Like, that's easy, years 1 and 2. What you're describing for the actual replacement of simulations, I think, is where education is going, where you can work on someone as an individual. They can learn at their own speed, as opposed to dealing with the, all the headaches of trying to get things together. Because it is hard to do sims, even for, OB, to get the physicians out of their clinics, to get everybody free from coverage and stuff. But that's great. I have a question for you, Melissa.
Yeah.
What's your thought on augmented reality?
It's super exciting. I think that, we'll just have to see when. This is one where I think the hardware just still has to catch up with all of the potential. So there are these kind of one-off, really incredible creations of, being able to just put on glasses, but see, a whale come out of, your gym floor in these really incredible ways. So I think it's exciting. I think it has the benefit of, on the one hand, I think you could say feeling either more or less real. It's sort of hard to say because you don't get that sort of encapsulation that a VR headset gives you, but you are able to potentially leverage it in different ways. So there are surgeons now who already are using right now a not very, I guess I'd say task directed version of it, where they can wear Google Glass for the 5 people who have it. And be able to see, though, the imaging study of, the spine that they're working on, sort of right in their head, having it sort of pull up and be able to even map that, some of the AR is now doing, onto the spine that they're actually looking at. So I think it's going to be incredible. I think it might even have, real applications outside of education, outside of sim, and really actually translate clinically.
This is a book by John Couch. He's one of the pioneers of Apple, and he was talking about where education is going. And he actually is a big believer in augmented reality over VR, because, VR, you're kind of siloed and you're immersed in that one environment. But truly, to be able to have like headsets on to see the patient with whatever you have overlapping is probably where it's going to go.
And tell the listeners what you held up to the screen.
So I'm holding up a book called Rewiring Education by John Couch.
And we can put that in the show notes too.
Yeah. Apple incorporated its first vice president of education. They actually had someone within the company that was dedicated to help encourage the educational mission. And they talk about, integrating technology into teaching, with the differences between virtual reality, like as Dr. Wong is describing, with headsets that completely immerse you into a different environment, versus something like augmented reality. And I think the easiest example that they give in the book, I never played it, but Pokemon Go, which, leveraged your smartphone and you could look at your camera, and then they would actually have images of these little Pokemons that you would capture. And so the thought is, if you had a headset with glasses, you could put in, MRIs or images. And then when you're actually doing the surgery, you can kind of see what you need to get to at the same time, as opposed to you being completely outside of that environment.
Yeah, absolutely. I think, if there's anything that's actually going to translate into the OR itself, I don't think any of us is that excited about being completely immersed, i.e. literally seeing the patient So I think that it would be augmented reality.
There's definitely some cases where I would love to be on a beach. Would rather be on a beach somewhere, but I think our patients would appreciate it if we were there. But yeah, I think of it more from the clinical side, the training, the teaching, but doing it for therapeutic is something I just had never heard of before. I mean, I'm with Tony, completely novel. Like, it just blew my mind.
Yeah, I've seen, we do a lot of ultrasound simulation, and I've seen those tools. I've not gotten my hands on the one where the headset and you're actually doing like fetal echoes. Have you tried that, Melissa?
Yeah, it's just fine. So there's like medical education that uses it well. And like there's a point in being in a headset. So actually one of the examples that I like to go to is not actually educating medical professionals, but is actually patient education. And it's where it's actually, I think, out of Stanford, where they do a lot of fetal surgery, and they have a simulation for the solemnization procedure in twin-twin transfusion. So for those who aren't familiar with it, it's basically twin-twin transfusion syndrome is where there's unequal sharing of the placenta. And one of the ways to treat that is to just hop into the uterus with the baby still inside, laser down the middle to get rid of those connections and then come out and remain pregnant. Super easy. But it also really hard to conceptualize as a patient. So what they actually created was this immersive environment where you are now, I guess I would say that you are like the laparoscope. So you are inside the uterus, and you're able to use your little joystick to actually perform the lysis yourself and see the unequal sharing then start to resolve itself. So it actually takes you into the environment. The particular ultrasound program that you're bringing up is sort of the other version, which is, it's a really cool simulator for performing ultrasound. I actually think it probably does the best job of doing that because you can slide around an abdomen. The only thing the VR headset does is make you feel like you're in a clinic and like you reach for a file folder in VR, but then you're still using the Pro. So
I guess the other thing with training though, with VR versus sim, having a simulation on a screen is you could track where people are looking. I mean, I want to know whether my residents are looking to identify the yurt or how much, what are they looking at right now? Because I know what they should be looking at, or I have an idea about what I think they should be looking at. But is there work being done, like tracking the actual users, like where they're focused? I imagine that could be a big part of it.
You know what? That's interesting. I haven't seen that for the purpose of anything in education. But I mean, the next Oculus coming out, one of its big advances is the ability to have eye tracking for any number of things, gaming things, for, biofeedback for some of the more relaxation type interventions, or I guess environments that you're dropped into, so that, if it sees your eyes darting around, it sort of like is cool down.
Or if you're in Meta, you can tell what I'm looking at.
Yeah.
Either of you guys, I know, Tony, you said your kids do. Have either of you guys had experience with VR? Do you have sets like at home that you use for fun?
I felt like I had to, right? Otherwise, I was just like...
For research purposes, right?
It's for research purposes. Yeah, but no, I did actually get one. And it's funny because despite, having piloted the VR, sort of the closest to like a meditation-y type intervention, I'm like the worst at meditating. I'm really terrible at it. And so actually doing that in VR is actually really helpful. Because I, can't look at my phone. I can't wonder how long it's been. I'm just sort of in my brain, I'm doing something else, even though I'm, I guess, actively relaxing. And then the other thing it's actually really fun for is exercise, which is just like something we can all do more of. But those are sort of my two favorite things to do on it. Not super great at gaming per se.
Yeah, we own one and probably used it the most at the height of the pandemic. And then it kind of, set to the side. I don't think we found like that game that kind of keeps us hooked. Beat Saber is a common one that people play as a party game, but we've not found one that really just makes us want to keep going back to it. The technology is really cool though.
And people are socializing now with this, right? I mean, that's what they make you think when you watch commercials and stuff, that people are actually like, you go to a virtual club or virtual party and communicate and interact with people.
I will say our last, I spoke recently at our virtual medicine conference, and we had like what is that called? AltSpace VR. It's kind of one of those environments, right? So you create your avatar, and then I think we were all put into this like picnic-esque environment. And not unlike in real life, I found myself just trying to wander away quietly. So I don't know. I guess life was actually imitating art. So successful immersion.
Melissa, at the onset, you were talking about some of the things that you're doing, some of the titles, and you mentioned AI. So I kind of feel like this is a nice place to put this. We talked about virtual and augmented reality. Where do you think AI sits in OBGYN and medical education writ large?
Oh, man. So I would say AI, the broad sort of topic of computers doing what we once thought would take a human, will/already does have effects in all aspects of becoming a doctor, like practicing as a doctor. The example I usually give is that every one of us has actually used AI already. If we've ordered, a hemoglobin electrophoresis in the first trimester of pregnancy, it's AI that's processing those. For the great majority, our CT scans already get triaged via AI. So when you get, your head scanned, if it looks bad, our system will actually move that scan to the top of the, sort of like what the tech would have done, right? Like sort of move it to the top of the pile if they were like, this looks bad.
Wow.
So it's actually happening, at the AI level. And then there's the work that I do, which is to really try to use AI to guide clinical decision making. The idea that essentially, we're all subject to all of these cognitive biases. Can we create AI and clinical decision support more broadly that helps overcome some of those and helps maybe be able to predict sooner and more accurately eventual outcomes?
That's fascinating. And I will tell you that students are savvy. I work a lot with the medical students when they're selecting specialties, and you hear about them, like they don't want to go into a specialty if they're worried about a computer taking their job. You hear about these things. Mm-hmm. What is your thought on the timeline for these things?
I think one of my favorite quotes around that is something like any doc who can be replaced by whose work basically can be replaced by a computer should be replaced by a computer. So I think it's less thinking about how it's going to, quote unquote, replace us per se, and more just how it's going to change the way that we practice. So, if a radiologist can now, instead of, being the person to sign off on, every darn plain, screening chest x-ray, can now actually have more time, might they actually be that first line that, God forbid, talks to a patient and actually counsels them around the initial findings, since it's certainly better than it being auto-released 24 hours later or less.
I've thought about that a lot because much of what we do now, we complain about, how, especially specifically with EMR, like the first iteration it's all based on billing, but like the first one I saw as a fellow at Michigan was just like, here's everything that's ever happened with this patient. You have like a 15-minute visit. Mm. And you're like, where do I even start with this, right? And so much of the work that we do now has been changed by technology. And I would say in many ways it's positive because we know more about the patients. But if I cannot find the important stuff in that. And the newer versions do a better job of, I think, at least are trying to find better ways to bring me what I need. But if an AI could go through and give me what I need, the thing that we all came into medicine, or many of us came into medicine to do, which is talk to patients, right? Have that face-to-face time that we're now all complaining about clicking in the corner. We can go back and do that again and allow all of this massive amount of data, have an AI person go, okay, here's their PAP, here's their ultrasound, here's the EMB, here's the stuff I know you usually want to know, and do that for you. It could allow us to go and do the thing that computers can't do, which is, I'll say that, and tomorrow they'll be able to do this better, but connect with, on a personal human level. Right. Eye contact, emotions, and those things. And I'm sure it wouldn't take much for a computer to out-emotion me some days, but that's the opportunity I see anyway.
Yeah, there's actually a really great book just to get started in where AI is impacting clinical medicine by Eric Topol, who's just written a bunch of digital health stuff, but specifically on AI, called Deep Medicine. And it's sort of, the title is really two functions because it's, play on deep learning, sort of a subset within AI. But then also on the idea of actually getting back to the deeper connections in medicine rather than, just essentially being, a glorified scribe/biller.
I'm glad you used the example of radiology, because it was a radiologist that I was talking to, and they told me like the amount of scans that they have to review on a given call night. And he said, bring it on. Bring on the AI. He needs some help with that. Melissa, you also mentioned informatics. And as we're talking about where we're at with technology and our ability to capture all sorts of data, the blockchain, what do you think about informatics? Where are we headed? And is that a necessary skill that every department should have somebody that specializes in that?
And for our listeners who may not know, what is informatics?
It's tech support. No, it's really, it's funny. The way that I like to summarize at least what I am getting out of informatics, or I'm trying to create in the space, is using computers to make it hard to do the wrong thing. And that's really what I think of it as, is just the idea of not so much just like, here's the right thing you ought to do, but how do I actually make it difficult for you to do the wrong thing? And whether that's the stuff that, drives us crazy, like best practice alerts, and or whether it's just tiny little nudges. So I think of, one study where they just changed it's hard to get more basic than this, but they literally just changed the default number of opioids being prescribed, like that came up. Instead of you getting to pick whatever number felt emotionally right to you, as long as you didn't change it, it was now going to only be 5 or 10 or something like that. And they dramatically decreased the amount of opioids patients were going home with and were making their way into the community with just these tiny little, sensical changes to care. And so some of the work I'm doing that is AI driven is around reducing the disparity in our aspirin recommendation for preeclampsia. So we're doing a really terrible job, and a particularly terrible job among Black patients in identifying those for whom aspirin was indicated. And so we have used our AI to do natural language processing to identify out of the chart who ought to be getting aspirin, and then serving that to the clinician, and in so much of a way that you actually have to just say, like, I've drafted up the order for you. It's like the equivalent of the person coming by with the sign here sticker and say, you're good with this, right? Like, we can put this person on aspirin. So it's really this idea of trying to make it hard to do the wrong thing. That is sort of my aim in informatics.
And I think what's really cool is when you use these terms like informatics and certainly VR, AR, all this technology stuff, it ultimately is getting back to the patient. It's not using technology as a wedge, but probably to do some of these tasks that are separating us, and, the potential to maybe to decrease burnout from some of the things that Mark brought up, being stuck with the EMR and billing. That'd be great to get back to that.
Yeah, I think that's why, that's a big part of the reason that I stay so invested, emotionally at least, and not in any way financially, tragically, in this space, is that we really need to be at the table. Otherwise, what starts getting measured is just what's easy to measure and not what actually matters.
Right. Another great book, Measure What Matters, right?
Oh, is that?
Yeah.
Dang, I thought I came up with it.
See if I can find the book to show you guys. But yeah.
We got all these good links.
Yeah, John Doerr is the author.
But right. That's the thing, is that if there's this entire ecosystem around sort of AI and healthcare that is just sort of 50 different ways to improve your bottom line, which I just don't find interesting, but also find a little on the border of nefarious. And so I feel like clinicians and patients and really everybody has to be aware of what's happening, because it's happening, period, the incorporation of all of these things into healthcare. And it's just a matter of us being there to help, herald the right questions.
Again, all of these questions you're asking, most of what gets measured is, like you said, what's easy, but also what matters to the people creating the system and the ones who built the EMRs. Our health system is very unique in that we are the only ones in the world that I know of. Everyone uses ICD-9, everyone uses CPT, but we're the only ones who use it for billing. And so the systems are built to collect billing information. And so if we actually had a system that was built to collect clinical information or a system that was built to help clinicians do their jobs. And I'm sure if we just have to show that spending more time with patients it makes us more money, I'm sure somebody will build the system. But yeah, I think, with med students, right? Applications, it's like we get these scores. I think a lot of us would take that student who maybe wasn't at the top of their game on a standardized test, but who showed up early, stayed late, like had all those things, like the Melissa Wongs of the world, who just like, who also was great at test taking too, but like the perfect resident, right? Like how do you find that person? And you were, but how do we find more people out there that are amazing humans who are great at connecting with people? But that's really hard to measure. And so we're stuck measuring what's easy. And so, yeah, I think AI and those kinds of things, I'm very naive to all this tech stuff. And with 13-year-olds and a 10-year-old, like I'm trying to get them out of tech and trying to like make, hey, call somebody to actually come over and talk to them, face to face.
You need to text them first that you're calling.
They don't even use text anymore. They're like on this other app. I'm like, what? Just go. Like, if you call them on the phone, oh my God, can you imagine how that would turn out? So I'm in my life now as a parent, I'm trying to do the opposite, trying to avoid it. But I guess maybe I'm just like a, yelling at the wind guy, right? Just like screaming at the reality of the world. I guess I should maybe get on the train.
It was your nickname in residency. So
oh boy.
Maybe that.
I wish I had a cool nickname in residency. But
well, I'm glad we have people like Melissa to represent us and the thoughts of physicians in this. And I know it gets scary. We've all seen the movies when you weaponize AI, and you can pick your different movie, Ex Machina, if you want to. But she's going to be our good representative.
It's always Terminator, Tony.
It's Terminator.
Yeah. I am so thrilled that not only are people doing this, but specifically you, Melissa, that you're doing it. Because
agreed.
I think the world of you as a clinician, but as a person. And I think if the people like you are at the table, if people like you are the ones driving this, if people like you are the ones making the decisions, clinicians will benefit, but patients will benefit. I mean, to have someone whose heart and mind are in the right place in helping to define this stuff, to create this stuff, like that's reassuring. That's hopeful in a way that I think a lot of doctors, when they show up every day and they've got their EMR and their huge patient census and just think this is the way it's always going to be. I think we don't have a lot of hope. There's not a light that we're working towards. At least not all of us see it. Not all of us know that it's coming. And so to be able to hear what you're doing and know that, people are actually working on making this easier and better for us. And this is the way it's going. And just just keep doing good work. And people like you are doing this as well. To me, is very reassuring, brings me great hope. And I'm lucky. I have a great job. I like what I do. But a lot of the stuff that I see and hear, the burnout, the stress, all those things, like that's where a lot of this comes from. And so I love hearing that it's the technology, like Tony said, that's actually going to bring the physicians back to the patient bedside. And that's incredibly optimistic, but also incredibly hopeful for me. So I love it. That's fantastic.
Thank you.
Thanks for having us, Mark. And thank you, Melissa.
That was wonderful. I'm now in a better mood. I'm optimistic about the world just because of you.
Now I'm thinking about, let's get a tiny car and go barbecue.
We have to find a small car. We have to find an excuse to get in a small car in some city where none of us live and go eat something.
And find that we got to Google the best fast food place. That was always the goal.
Always the goal. Always the goal. Well, thank you so much. I know you guys are both incredibly busy. Thank you for being a part of BackTable, and we hope to have you on in the future to hear what's come next.
Thank you so much. This is great.
Thanks, guys.